Psychiatric drug withdrawal, harm reduction, not judgment. This is printed in Mad in America, 2025. Can people be scared into harm reduction? Since going off psychotropic drugs is a frequent topic of conversation, we present it as a context for mutual aid in action. Harm reduction means reducing the potential for something terrible happening, rather than guaranteeing a good outcome. Because medications are inherently unpredictable, tapering psychotropic drugs carries risks, including withdrawal symptoms and, in extreme cases, protracted withdrawal syndrome, suicidality, and disability. However, tapering usually reduces the risk of harm compared to abrupt discontinuation, cold turkey. It is a harm reduction technique that helps minimize these risks when discontinuing psychotropic medications. Some well-intentioned people on social media take an aggressive approach to convincing others to taper slowly, sometimes insisting that tapering may take years or even a decade or else. The issue isn't the advice to taper itself, but the fear-based messaging that can paralyze people, making them too afraid even to attempt to reduce their medication. Telling people they're destined for the worst possible outcome can create a self-fulfilling nocebo effect, reinforcing the very dependence they seek to escape. Conventional mental health care already uses fear to enforce obedience, warning of disaster if patients deviate from their treatment. In withdrawal communities, the same authoritarian or else may come from a desire to protect, but it's still punitive and unkind. When psychiatric survivors warn that going off will be worse than staying on, we risk reinforcing the exact same compliance once imposed by the psychiatric system. Good advocacy does not rely on fear or shame. No one can predict the future for any individual, and enforcing compliance through intimidation only mirrors the very psychiatric system many seek to escape. To our knowledge, every study on psychiatric drug treatment or withdrawal shows different people experiencing different things. There's a range of outcomes. While going too fast off of psychotropic drugs may end in unmanageable withdrawal symptoms or crisis, some people have come off their drugs quickly or even cold turkey without major problems. When speaking to someone who has just come off of psychotropic drugs, no one can predict their outcome. Some taper quickly, face difficulties, and are told they're failed by not doing it right. But they did the best they could with the information they had when they stopped their drug. Telling someone in distress their suffering is their fault is not support. It's shaming. Should you tell each person to expect the worst and then walk away? Warning others that protracted withdrawal will destroy their life forever can push an already frightened person into panic or even suicidality. Every day, people terrified by careless comments in our communities seek reassurance from peer counselors. Instead of spreading doom, let's foster support and hope in our communities, helping people find the escape hatch. How can we communicate harm reduction principles of tapering without emphasizing the worst possible outcomes? Much is understood and very little is known about what happens when people go off of antidepressants and other psychiatric drugs. As Framer writes, the entire field, including addiction medicine, has overlooked the significance of debilitating psychotropic protracted withdrawal symptoms and consequently the importance of individualized tapering to minimize withdrawal symptoms. While it's wrong to deny the reality of protracted withdrawal, it's also wrong to say that going off of antidepressants or other drugs will always result in protracted withdrawal. We need to acknowledge that the results are unpredictable. It's misleading to urge others not to fall into despair for the future. Even interpreted critically, studies show that a sizable proportion of people, perhaps a third to a half, can quit antidepressants in the most haphazard ways and do well in the end. This is not to agree with the current state of risky tapering practices among medical professionals. To avoid injuring half, they should employ harm reduction techniques for everyone. But this diversity does show that going off of psychiatric drugs in an uninformed way is not always disastrous. And recognizing this roll-the-dice reality by no means discounts the toll in withdrawal syndrome paid by the unlucky half in these studies. Throughout our entire careers in this work, we have shouted from the rooftops. Gradual tapering is harm reduction. If you've had a hard time coming off, it might mean that you need to try slower next time, and we agree with Horowitz and Moncrief, who recommend gradual hyperbolic tapering as a standard of care, relative to each individual experience of what is tolerable in the process, and balanced with choice around all of the unknowns and the ongoing harm caused by medication exposure. The rate of reduction requires striking a balance between harm reduction caused by ongoing exposure to the medication and harm caused by too rapid reduction, a balance that will vary for each individual. Individualized tapering is precisely that, individualized. In the not too distant future, we sincerely hope more people will be able to find medical professionals who know how to guide individualized tapers in this way. As for the method, any tapering is better than no tapering. There is no dogma to this. Peer support groups have long recommended exponential tapering. Dr. Horowitz has shown that hyperbolic tapering may be more closely related to the actual drug action. Either method involves reductions getting progressively smaller, and either could work. But the harm reduction strategy depends on the individual's situation. In some cases, rather than continuing the drug by slow tapering, going off quickly and risking withdrawal syndrome may be advisable. People who are presently suffering severe adverse drug effects, such as akathisia, might be better off tapering rapidly or simply stopping the drug. In these situations, the present drug risk may be greater than the potential withdrawal risk. A shorter rather than longer taper being a harm reduction strategy to reduce the potential for worsening drug effects. Every time we meet someone considering psychiatric medication discontinuation, let us calmly and compassionately educate around gradual tapering with support as the standard of care, as it should be, as well as standards of mental health that are patient-centered, collaborative, and respectful of individual preference and choice. Questioning the pill, not the patient. The fact is, some people choose to be treated with psychiatric drugs with full knowledge and informed choice and don't want to stop their drugs. They may believe that the drug regimen has enabled them to have a good life. They may have made the best choice for themselves at the time, and they may have been one of the people, as most psychiatric survivors were. We agree with wondering that we still do not understand the most important mechanisms causing psychosis and relapse, nor are we able to predict who is dependent on antipsychotic drugs after remission of psychosis and who is not. To accept this is important but may be even more important to work together with your patients and try to find the best individualized treatment for every single person having to deal with psychosis. You may recall the Post Your Pill campaign on Twitter, now X. This was supposed to be an anti-stigma campaign, which is a little odd because it appeared to praise for drugs instead. Regardless, their posting their pills attracted many dire warnings from activists trying to educate them about drug dangers. Sometimes these well-meant cautions veered into dire warnings or personal insults. About 10 years ago, the term pill shaming was coined in defense of those committed to their drug regimens, to deride those opposed to the medication. One person's poison can be another's remedy. But what about when we suspect the person's drug regimen is dangerous? Questioning the pill has to be done with greatest compassion for the patient, sharing and caring, not overbearing, exaggerating the risk, harassing, or calling the person names that might cause them further distress. It's a fine line between questioning the pill and insulting the patient. If a person is convinced of the value of their drug regimen, harm reduction can mean supporting the person without judgment, shame, predicting a bad outcome, or coercion. And if you can't tolerate their decision, it may be best to step away. Offering mutual aid, whether people take their drugs or stop their drugs, is an individual choice where the future is unknown and can't be controlled by anyone. People have the right to take informed risks if that's what they want. Respect for autonomy and self-determination in the context of informed consent is at the heart of the patient's right movement. What about the basis for informed consent? Educating people about risk means calmly informing them that certain bad things may happen and can happen, may and can, to allow for the many exceptions. Psychiatric drugs may induce disastrous effects, akathisia, suicidality, violent behavior, enduring sexual dysfunction, severe withdrawal among them, and they do not always do so. The reality is that an unknown number of people will experience the worst, which should be enough to give anyone pause, but this will not happen to everyone. Even if the probability of an adverse effect is known, very rare in any aspect of psychiatric drug treatment, no one can predict it will happen for any individual. Out of caring, let us humbly share our knowledge and experiences. Let us not judge, shame, or predict the future for the people we meet, but instead communicate calm, compassion in the face of choices without certainties. We recognize these are messy, complicated human realities, and we can't control how diverse and individual each person's journey will be. Trust people to find their own way. In supporting someone, be aware of each individual's sensitivities, vulnerabilities, and resources. Acknowledge that we know and what we don't know. And the most important lesson of all, learn and decide for yourself. The direction forward is within you.